There we go. That's a slightly entertaining start to the meeting, but welcome everybody. This is the second time, not the first time that we've done this meeting, but welcome to the second time. It's a pleasure to have you all here. I'm Simon Hansom. I'm one of the electrophysiologists here, and I also run the Inherited Arrhythmia service. It's great to have Dr. Green, who's co-chairing with me today as a friend and colleague. We will be joined later on by Jason Roberts. He's in a meeting until about 1:30, and then he will be joining us at that stage. We've tried to find a good balance for this meeting between clinical work and then future direction, and we hope that Jason will bring some of that translational work from his research and just share some insights with us today. We really want this to be an interactive meeting. It's great if you are able to ask us questions. What I would prefer, if it's possible, is that either pop your message into the chat and then at the end I'll go through those. If you would like to personally ask your question, then just raise your hand and then I'll direct the microphone towards you, virtually at least, so that you can ask that question at the end of each presentation. And then probably at the end of the session, we'll have a group discussion with the three of us as well. With that, let's move on, and I'm going to introduce Dr. Martin Green, who I'm sure all of you will know. But Dr. Green, it's great to have you. It's always great to hear you speak about ECGs. And again, excited to hear what you have to say, because we always learn something. I'll let you share your screen if that's okay.
Thank you. Let me share my screen and I can try to get this figured out. I can't see my screen. Are you looking at it?
Yes, but it's not the actual presentation. It's your PowerPoint.
I understand that, and I can't change it now.
So just go back to share, stop sharing, and then if you play the presentation and then do share again, and then just select the full window.
Yeah, but my taskbar has gone away when I did that, so I can't find the share now. Let me go back again, display settings. Sorry, guys. Can you see anything?
Just your face, Dr. Green. We don't see you sharing right now.
Well, I turned off the sharing to get the other screen on.
Mm-hmm.
And in doing so,
excellent. There it is.
You got it now.
Indeed.
Okay. So we're talking about inherited arrhythmias and cardiomyopathies. I'm really going to focus on the electrocardiogram in inherited arrhythmias and cardiomyopathies. Oh, and it doesn't advance now. I do have a disclosure. I edited a book on the electrocardiography of inherited arrhythmias and cardiomyopathies. If everyone in the audience bought 3 of these, I would probably get a check for 25 cents at the end of the year. So just for a disclosure on that one, I have no other disclosures. So when we talk about inherited arrhythmias, we talk about a few things. I'm going to spend a little bit of time on long QT syndrome, and Simon will as well. Brugada syndrome, CPVT, catecholaminergic polymorphic ventricular tachycardia. A little bit of time on J-wave syndromes because they really interest me, and not much on short QT. And then I'm going to talk a little bit about some of the inherited arrhythmogenic cardiomyopathies. So the main message here is that these are not always easy to diagnose. The ECG may fail to identify affected patients and may fail to identify family members. This is true for all of the channelopathies, and we may require unmasking. And I'm going to talk a little bit about unmasking, either with stress tests or pharmacologic unmasking, because that really becomes some of the cornerstones of our diagnostic testing. So we'll start with long QT syndrome. It's the single most common ion channelopathy, about 1 in 2,500 healthy births. many ionic mechanisms, mostly in an autosomal dominant, but not exclusively autosomal dominant inheritance. And a lot of heterogeneity in patient presentations, including sudden death to lifelong asymptomatic carrier with the same gene. Only 1/3 of people who carry the specific mutated gene that codes for this abnormality, only 1/3 of them will be symptomatic in their lifetime. And many gene carriers will have a completely normal ECG. So let's talk a little bit more about long QT syndrome. We specifically talk mostly about long QT1 and long QT2. Simon's going to go into this a little bit more. You see the ECG with long QT3, which is basically a late T wave. But long QT1 and long QT2 are really related to the repolarizing currents, the rapid one and the slowly repolarizing currents. IKR, rapid, IKS, slow. And the rapid one shows up very early during activity. And what I'm going to show you, it may even show up with just standing up from a supine position. Here is a 51-year-old man with a history of cardiac arrest. 4 of 11 siblings died of a heart attack. Remember that when someone says a heart attack, it often means sudden death. Here is the resting ECG. It is completely normal. The coronaries were normal. The echo was normal. The resting ECG is here. We stood this patient up, and look what happens. Look at V4 and V5. Look at V3. Look at lead 2. The ECG, the QT interval immediately stretches, and we get a hump on the back end of the T wave, best seen in lead V4. So this is an example of a physiologic stress that brings out long QT that is otherwise not apparent. This is from Sami Viskin. I want to show you this because, again, on the bottom panel, when we look at this, we see over a few seconds, just standing up, what we see is this change in the T wave with a secondary hump and a marked increase in the QT interval over a few seconds. That's at the beginning, and that's why that we know, it's one of the reasons we know it's the rapid repolarizing current that is affected. Okay, so that's long QT2. Brugada syndrome is another one, possibly lethal, often asymptomatic, and the ECGs are often normal. So we do have to have ways of bringing out the abnormal ECG. This is the typical Brugada syndrome. You look in V1 and V2, you see ST elevation and a coved T wave, ST segment with a inverted T wave. That's the classical Brugada ECG. This is a Brugada patient, entirely normal ECG. There are dynamic changes, and the same patient at another time, if you look at lead V1, shows ST segment elevation, cove ST segment, and an inverted T wave. So these are dynamic processes that we need to be able to diagnose by changing the physiologic parameters that are really going to change this ECG. We do this sometimes with a drug infusion. In Canada, we use procainamide. In other countries, they have other drugs available. And quinidine actually may normalize the ECG. So if you look at the control on the left, we see a not quite ST elevated one. We see after procainamide, marked ST elevation in V1 and V2 with the inverted T wave. And when the patient started on quinidine, a normalization of that ST segment in T wave. So these are physiologic changes that we see with stressing the system, in this case, pharmacologically. We can also do it by non-standard ECG placement. We put V1 and V2 in elevated spaces, and here we see the baseline ECG. Although there is some ST segment elevation in lead V2, it would not meet the criteria for Brugada syndrome. We place V1 and V2 an interspace higher and look at V2 now. ST elevation, cove T wave, inverted T wave. This is classical Brugada ECG just by elevating the V1, V2. So we need to know that Brugada syndrome, these patients can have normal ECGs, and we need to find ways to bring out the typical Brugada pattern. CPVT. So here is a very, very abnormal rhythm strip, bidirectional VT with ventricular fibrillation. This now is the case of I'm going to show you a 16-year-old boy, but bidirectional VT is the classical VT with CPVT. It has a very high mortality rate. It is usually associated with the RYR2 gene, and it's related to intracellular calcium overload. There are other ionic and genetic mechanisms, but the most common is RYR2. Here is a 16-year-old boy who had a syncopal episode while playing soccer. ECG completely normal. Really important. The red flag here is the syncopal episode occurred during activity. So we put him on a treadmill, and this is what we get. Bidirectional VT, lots of ventricular ectopy at low levels of exercise. Here's his Holter monitor. Again, bidirectional VT while horsing around with his girlfriend. Don't ask me what the horsing around involved, but you can see some sympathetic stimulation and bidirectional ventricular tachycardia. Highly lethal event. This young lad had syncope while playing soccer. That is the red flag. That is the reason you have to do the stress test, even if his baseline ECG is normal, and we have to make a diagnosis. I won't talk about treatment today. J-wave syndrome. This is relatively recent. This was first described in 2009 by Hassager. And what we see here in his description is this very abnormal J-wave and ST elevation and polymorphic VT initiated from that. This is from the Casper registry, 2009. So these are people who had sudden death without any evidence of cardiac abnormality. And here, once again, on the second strip, we see marked J-point elevation, an episode of polymorphic VT. And at the very end, here's the beginning. And here, several seconds later, is the end. This is completely normal, total normalization within seconds of the ECG. Here's one of our own patients on a Holter monitor. This patient had an ICD, but on his Holter monitor, we see just before his polymorphic VT, this abnormal J wave on the first beat of the strip. We see the polymorphic VT, and at the end of that, we see a completely normal. This is the same lead. The lead 2 and the channel 1, channel 2, channel 3, the same lead. This change happens over seconds. And this polymorphic VT came during this ST and J wave elevation. This is one of those unusual strips, and we have to bring it out, obviously. We have to bring it out if we can't see it in order to get the correct diagnosis and the correct treatment. We don't yet have a single genetic mechanism for this one. Short QT syndrome really is the opposite of long QT. It's generally the same genes, only their gain of function rather than loss of function. And again, this is relatively recent. The genetic defects mostly in the same genes that cause long QT syndrome. And here's the ECG. Jason can talk to you about it later if you have questions. Almost no ST segment. A little J wave and this tall peak T wave with a very, very short QT interval. Lastly, I'm going to talk a little bit about some of these structural syndromes. We're going to talk about the inherited cardiomyopathies now, the arrhythmogenic cardiomyopathies, rather than the channelopathies. So ARVC, there's lots of arrhythmogenic cardiomyopathies. We see lots of them. I'm not going to go into all of these. There are some that tend to be more arrhythmic than others. You heard a little bit about that this morning. Here we have a 48-year-old former Olympic middle distance runner who had a cardiac arrest. Middle distance runner, a highly trained athlete. Following her cardiac arrest, here is her ECG. She has deep T wave inversion in V1 to V4 and a flat T wave in lead V5. This is fairly classical for the arrhythmogenic right ventricular cardiomyopathy. We will talk briefly about some of the other arrhythmogenic cardiomyopathies, but this should really raise your index of suspicion. And there's that deep T wave inversion V1 and V2. This is a 36-year-old high school teacher presented years ago, about 25 years ago, with a syncopal episode while playing broomball. Once again, the high index of suspicion, the reason to go further is the fact that he had syncope during activity. Very worrisome. Here's his ECG. I'm going to blow up lead V1 for you. And in V1, you can see this late little ditzel on the end of his QRS, and you can see this slow upstroke in lead V2. There they are. And this is an epsilon wave, one of the giveaways that's typical for arrhythmogenic right ventricular cardiomyopathy. There are many genes associated with arrhythmogenic cardiomyopathies. I won't go into all of them, but some also associated with conduction disease, low voltage, other arrhythmias which are not specific, mostly non-specific findings, but you have to have a high index of suspicion. Here is a LMNA, a Lamin gene mutation. They almost always have conduction disease in the LMNA. And here we see a very long PR interval, typical of the Lamin cardiomyopathy. Hypertrophic cardiomyopathies, various variants, usually associated on echo with septal hypertrophy. I'm going to show you a couple of ECGs. This is the apical variant with deep T wave inversion of the precordial leads, plus voltage criteria for left ventricular hypertrophy. PRKAG2 cardiac syndrome, I actually first described it, which is why I'm showing it. But there are other reasons because it's associated with multiple abnormalities, including atrial myopathy, conduction disturbances, ventricular hypertrophy, and pre-excitation. So all of those are part of the syndrome, often sinus node disease, AV conduction disease. And here is a patient who has pre-excitation, clear WPW, with gigantic voltages at the age of 22. He has both LVH and pre-excitation. So, conclusion. What are the clues that talk to us about inherited arrhythmia syndromes, inherited cardiomyopathies? Often the ECGs are not diagnostic. They often overlap with normals. We have to bring out the abnormality with some form of physiologic or exercise stress. Provocative testing often needed. We have to start with the appropriate clinical index of suspicion. There are certain specific features such as the bidirectional VT that we see in CPVT, but mostly they are non-specific. It's the high index of suspicion that counts. I can answer any questions later. Dr. Hansom will direct questions as needed. So I'll stop my screen share. And
Superb.
questions you want now, Simon?
No, I mean, superb presentation. I love the ECGs. They're always great to see. If there's any questions now that people would like to ask, please raise your hand. If not, you can submit them into the chat, and then we can have a panel discussion at the end of the meeting if there's other questions that come up. I think from my side, Dr. Green, it's always nice when you see these beautiful ECGs that seem to have a great correlation from your phenotype into your genotype, but you make the point that often there's so much overlap between those things. What's the kind of message from you in that regard? I know you touched upon it, but seeing a normal EKG, clearly a big pitfall, but seeing an EKG that might look like a condition, but not falling into a trap of closing your mind off to other possibilities. But what's your approach in that scenario?
So I think the take-home message is you have to have a high index of suspicion based on the history, based on the family history, and you have to go forward with provocative testing. Long QT often has a normal QT interval. I know you're going to talk about measuring the QT interval and how we make that diagnosis, but remember that a normal ECG does not rule out long QT syndrome, and there is an overlap between normals and people with genetic long QT syndrome. So you have to have a high index of suspicion. You have to be willing to go to the next step.
It's often a challenging clinic, isn't it? Because you see somebody who's young and they look very well, and then you take the history and they've been syncopal when they're playing soccer.
Or a family member.
And it's the basics that matter, no? That is a worrisome story, and we have to just be cautious we don't dismiss it because everything looks so normal. That's great. I don't see any other questions in the chat at this stage, and I can't see any hands raised. So I'll move on and just share my screen and then come on to talk about long QT. Good. Just confirm for me, Dr. Green, that you can see that?
I can.
Beauty. Thanks. Can I just remind everyone as well, could you just make sure that you keep your microphone muted if possible, just so that we don't get background noise, because I can't mute you if you start speaking. That's great. Thank you. Okay, so title of my presentation was How to Assess a Patient with Suspected Long QT Syndrome. And the focus of this presentation mostly actually is to do with the assessment. It's not to do with the treatment. And that's because getting the assessment right is got to be the critical step. So I don't have any disclosures. There are book chapters, but I don't get any money for them, so I haven't put them here. From an overview point of view, we'll have a little look at the background of long QT syndrome, and then we'll touch on why does the QT duration actually matter? Is it relevant? Why does it matter? We'll look at how we assess these patients clinically, and ultimately try and make the correct diagnosis. We're also going to touch upon some of the discussions that Dr. Green's had regarding provocation testing. And also I'm going to show you some of the care pathways that the Hearts in Rhythm organization published last year, which tries to standardize care for these patients. So long QT syndrome as a background, most of us will know that long QT syndrome falls into two main groups, those with congenital or those with what would be considered acquired long QT syndrome. And the focus of this presentation will be on the congenital form. We are going to talk about acquired, but mostly in a way of being cautious about how those patients are managed and not dismissed because of what may be hiding underneath. So from a congenital point of view, long QT falls under this term of a cardiac channelopathy. And the key is that it predisposes patients to ventricular arrhythmia and sudden death. And as we've seen on some of the beautiful ECG examples from Dr. Green's presentation, we see abnormal electrical repolarization and QT prolongation. It's kind of tough to estimate the true incidence and prevalence, but prevalence is estimated at around 1 in 2,000 individuals, but does appear to affect women slightly more. But if we step back and look at a different cohort of patients, so if we look at patients who have died suddenly below the age of 50, who then in retrospect are assessed further either post-mortem with molecular and genetic analysis or by phenotyping and assessing family members, we know that about 21% of those individuals will ultimately be shown to have had long QT. And if we look at patients who have survived a cardiac arrest, and that's once all other typical causes like coronary disease or structural disease have been excluded, about 15% of those individuals are found to have long QT syndrome. Ultimately, it comes down to the cardiac action potential, and that depolarization and repolarization rely on what's called voltage-gated channels. And Dr. Green has touched on this and will build upon the concept, but these channels are made up of primary and auxiliary units. And essentially the primary unit forms a pore within the membrane that selectively allows ions to pass through. And the auxiliary beta subunit, if you like, is able to influence the function of that main primary alpha subunit. So the vast majority of cases that we see of long QT are because of defects in that primary alpha subunit, either for potassium or for sodium channels. And the other interesting aspect of this is that the behavior of these channels can be influenced by sympathetic tone. And that's been touched on earlier with the role of looking just from a sitting to a standing position in patients with long QT2. We can see that just that small amount of sympathetic tone can bring out some of their changes. So there are three major autosomal dominant genotypes, and they make up the vast majority, 80 to 90% of the identified mutations. And those are long QT1, 2, and 3, with loss of function in the potassium channels for long QT1 and 2, and then gain of function in the sodium channel for long QT3. So what are the challenges? Number one challenge is trying to understand what actually is a normal QT interval. And that's really difficult. In an adult male, a QTC at 450 or above, or 460 and above in a female, increases our pre-test probability of long QT, but it does not mean that they have the diagnosis. Particularly in males, we can see that a borderline QTC can actually extend up another 20 milliseconds, up to about 470, and in women by the same amount, up to 480 milliseconds. And there's considerable overlap, therefore, in the normal population, with about between 1 and 10% of people having a QTC that's above their normal reference cutoff. And equally, we see the opposite, which is people who are known to have long QT syndrome, genotype positive with the phenotype. 40% of those may have normal range ECGs at any given time. Again, here I put a flag to acquired long QT. It's fine, we see a lot of people who are on multiple medications that prolong the QT interval, but it's important that we're still diligent in how they're assessed, because they should have, where possible, the offending medication removed so that we can then reassess them again. Because actually there is some very good data to suggest from cohorts that if you look at those patients, you remove the offending drugs, and then some of them went on to have genetic testing performed, about 1 in 4 of them actually had an underlying pathological variant in a known causative gene. So they shouldn't just be dismissed as being acquired. So why does the QTC matter? Well, if we look at essentially the risk, so this is the percentage risk of a cardiac event. So a cardiac event is either a syncopal event or a serious arrhythmic event. So this is the blue bar. And the orangey red bar, depending if you're colorblind and what your screen looks like, are the serious arrhythmic events. So these are people who have survived a sudden cardiac arrest or who have died as a result. And we look at how the QTC and that risk changes. And when we get to around 500 milliseconds, we see there's a significant change in these very serious arrhythmic events. And this is over a 22-year period of time in patients who are from between 18 and 40 years old. So that's saying, your patients with QTCs of 550 and above, within those first 4 decades of their life, are going to have around an 18% chance of either dying from a cardiac arrest or surviving a cardiac arrest, but a very, very high impact risk for their lives. And it's a little bit more detailed than that. So this was some work by Silvia Priori, and we can actually look at a breakdown depending on the type of long QT, so long QT1, 2, and 3. And if you look in groups long QT1 and long QT2, you can see that actually for men, particularly with a QTC less than 500 milliseconds, they seem to have actually the lowest risk, followed by the women who have a slightly higher risk. And you see that women break away around the time of puberty and their risk seems to increase, certainly for long QT1, but markedly in long QT2. And that's because for females, the risk significantly increases around the peri and postpartum period, and that may account for some of that branching off, and then it levels off as they get a little bit older. For men, it seems that if men have a QTC over 500, they seem to fare badly across the whole board in long QT1, 2, and 3. So how do we assess these patients? Well, the question is, how do they get to us in the first place? So how does the question actually get asked? Is there a problem here? So some of these patients have abnormal baseline investigations. Some of them have an abnormal personal history, or they're found to have a long QT. Some patients, we find that they actually have an underlying established family diagnosis of long QT syndrome, and they get referred to us for testing because it's been identified in a family member. Some of them just have this family history of sudden cardiac death that's not otherwise specified. And so part of our evaluation is to see if they do have an underlying channelopathy like long QT. Some patients are cardiac arrest survivors, but there's this increasing number of individuals who are being referred to us who have been found incidentally to have a pathogenic or likely pathogenic mutation in one of the known causative genes. And some of those are being done because of developmental issues, and they're having whole exome sequencing. But actually, we're seeing a growing trend where employers are offering their employees the option of having genetic testing performed. So these are asymptomatic individuals who are then suddenly told that they have something that could be troublesome, and that's a very hard thing for us to assess in some situations. So really, it comes down for me it has to start with a good history. And Dr. Green touched on this. You know, that young child who's syncopal playing soccer shouldn't be dismissed. That has to be pursued because that is a really worrisome red flag. So personal history, if they've survived a cardiac arrest, things are a little bit easier in some ways. But there's other non-specific things that we may find. Definitely seizures can be a big one. Having polymorphic VT, ventricular arrhythmia, in itself can provoke a seizure. But certainly within long QT, we also see overlap into seizure, true seizure disorders themselves. But other forms of syncope are also very relevant. Some patients have palpitations. Other patients can have episodes during exercise. And we know typically that patients with long QT1 are more prone to their events during exercise. And so we often take a very detailed history about the levels of exercise they're involved in. Are they doing competitive training? But also swimming seems to be a very bad thing for patients with long QT to do. And whether that's because they suffer the same syncopal events during exercise, but because they're face down in water, they don't survive, or whether it's something to do with a cold water change in autonomic activation is unclear, but definitely swimming is something that we strongly talk about with them in clinic and the relative risks. Nocturnal events are also very important. Some patients, particularly those with long QT2 and 3, may have events during periods of rest and sleep, particularly for long QT2, it's when they're startled. But I often ask them about episodes where maybe their partners said that they've been unresponsive or seizing in the bed that they've not been aware of, or incontinence overnight, that sort of thing. A detailed medication history is essential because of the potential interactions with medications, and this is a key cornerstone of the management of these patients, is to stress the importance of avoiding drugs that may actually provoke and worsen their QTC and increase their risk of an arrhythmia at that time. Social history, illicit drug use, alcohol use is critical, and really a thorough 3-generation family history. And we're focusing here on family histories of everything, you know, family history of unexplained syncopal events, family history of sudden death in odd circumstances, drownings where people could swim, or car accidents where no one was involved and it was unexplained. Also other aspects. So for example, sensorineural hearing loss. We know that there is definitely an overlap here in Dravet-Lang-Nielsen syndrome, where patients can have sensorineural hearing loss, and they have a very, very high risk of life-threatening events at very early stages of their lives. So there's overlap into that aspect as well. So not to miss, sometimes we see people in a hospital setting, and one of the challenges there is that you look at the chart, you don't see much that's an offending agent, if you like, that may be causing an acquired long QT. But don't forget things like the EMS or the family doctor who gave them antibiotics last week that they'd finished by the time they came into hospital. Don't forget electrolyte abnormalities. Don't forget that post-ROSC people have abnormal repolarization. And myocardial ischemia and structural heart disease are still very key causes for long QT. We start again with the 12-lead ECG, and this is a young lady who I follow in clinic who unfortunately has an alcohol misuse problem. She's not compliant with medical therapy. But even without me putting calipers on here, you can see that her QTC is markedly prolonged and her repolarization looks abnormal, and she has confirmed long QT1. So how do we measure the long QT? This is sounds straightforward, but surprisingly can be challenged. And thank you, Dr. Green, for saving me making another animation. But essentially what we want to do is look at the tangent method. So here we're going to draw a line at the terminal steepest deflection of the T wave. So here's the line. And then we're going to identify where the baseline is. That's your baseline. Then we're going to identify where the QRS onset is. And then we're going to identify where our tangent line joins in with the baseline. And then we measure the distance between the two, and then we correct it using Bazets. And here we see, even without measurement, it looks long, but here you can see it's extremely long at 571 milliseconds. So we touched on the role of provocation testing, and provocation testing came out of this recognition that actually there was a relationship between sympathetic stimulation and cardiac events in some people with long QT, and furthermore, with them developing torsades. We know that the event rates are reduced by beta blockers. And we, as I said earlier, know that particularly for long QT1, exercise-related events do dominate. So approaches to provocation testing really took three main forms, but two of them were mainstream, but we've cut back to one now. And the main one that we've stuck with is exercise testing. And that was because epinephrine challenge, often there was a lot of variability in how a patient would respond. We often got other arrhythmias that would made it more challenging to interpret the results. And also there was very poor inter-observer agreement when people retrospectively looked at data. And there's some very well-known and publicized cases where people have been, and families have been, inappropriately diagnosed with long QT syndrome based on an epinephrine challenge. So the main focus has been on exercise testing, and the key paper was from Raymond Tsai, and he basically derived and validated the use of exercise to try and predict the underlying presence of long QT, both genotype, but also the presence of long QT itself. So this was shown earlier, this slide, and basically what it shows is how during exercise, our delayed potassium rectifier channels influence the shortening of our QT. Dr. Green showed a beautiful example of where at very low levels, changing from laying to standing, we see notching appear in the T wave. But in those individuals with long QT, they still have preserved IKS. So as they exercise, their QTs do begin to shorten, and at peak exercise, their QTs can look very normal. But in people with long QT1, where they have an issue with the IKS, what we see is that actually they fail to shorten the QT during exercise, and their QTs become progressively longer throughout. So this study was fantastic because suddenly it gave us a very easy way of assessing our patients. And what they found was that a cutoff of a QTC of 4 minutes of over 445 milliseconds gave a sensitivity and specificity of predicting the presence of long QT of 0.9, which is fantastic. Furthermore, because of what I've just shown you on the last slide and how we can exploit the behavior in long QT 1 and 2, they found that actually if you went back and looked at the 1 minute post-recovery, if the QTC was over 460 milliseconds, it had a good sensitivity and specificity in predicting people with long QT1. And this has gone on to be independently validated in other studies as well. So how do we put it all together? Well, ultimately, it comes down to your clinical suspicion, but also it's been underpinned by the Schwartz score. And the Schwartz score basically assigns a score based in three main categories. So ECG findings, the clinical history, and the family history. And we're looking for a score of 3.5 and above. And that's going to give you a high probability of having underlying long QT. And what that means is if you've got an individual with a QT of 470 on an ECG, it makes us just think twice instead of jumping forward and being eager with our diagnosis. It just tells us that we're not quite there. We need to look for more information. So the general consensus now is that if you have a Schwartz score of 3 and above, we would certainly offer genetic testing, sometimes to those with lower scores. But generally, we want 3.5 and above to have a high probability. We'd offer genetics at 3 and above. But international consensus opinion generally also says that if you have repeated ECGs, with a QTC of over 500 milliseconds, in the absence of any offending drug, then that's very high probability. And there's also a discussion now about if you have an unequivocal pathogenic mutation in one of the known causative genes, then maybe that may be enough. But there's always a caution note with that should be interpreted by an expert in genetics before coming to that conclusion. And finally, I just wanted to finish with the HERO care pathway. So care pathways have been published for the management of all of the inherited arrhythmias, and it really helps to standardize how these patients flow to the clinic, but how they're also worked up and evaluated and ultimately managed. So in summary, the diagnosis of long QT can be challenging, but you have to have a very high index of suspicion. Provocation testing has become the cornerstone of diagnosis, but I have to throw caution to the wind in dismissing these apparently acquired cases so that they're not inappropriately dismissed. Ultimately, because of the risk of sudden cardiac death and the availability of an effective treatment, we want to identify those patients at risk to protect them and their families. Thank you so much. We can take any questions now. Otherwise, we'll move on to the end of the session after Jason. I'm just going to stop sharing here. Is Jason in the audience?
I'm here.
Looking. Hey, you're there.
Mm-hmm.
Hi, Jason. Thank you for joining us.
Yeah, my pleasure.
Excellent. Dr. Green, would you like to formally introduce Jason? Oh. Is Dr. Green still there? Jason, thank you for joining us. It's great to have you here. Jason is
I'm on now.
Oh, he's here. Welcome back,
Go
Dr.
ahead.
Green.
Go ahead.
No, you introduce Jason. You go for it, as we'd planned.
Jason was one of our residents several thousand years ago. So I've known him for a very long time. He is now at Population Health Research Institute at McMaster. He's done unbelievable work in this field. And he's now looking at targeting gene therapies for specifically targeting the genetic mechanisms of these arrhythmias. Jason.
Excellent. Thanks so much for that kind introduction, Dr. Green, and thanks very much to both you and Simon for inviting me to give a talk at this great symposium. My talk, it's more about, I think, the tools, emerging tools that are going to be used for these conditions. Some have reached clinical prime time, so there's clinical trials for some of these tools now, and some others we expect to see in the next few years. So it's a bit of a change of pace relative to the other two talks. I guess it's a bit more futuristic, but the future is now. All right, so in terms of the things that we'll talk about, so the different tools. So one is RNA knockdown. So we'll talk about the different types of RNA knockdown. It's being used for some other areas of cardiology now, and that it hasn't gotten to the heart in humans yet because of the challenges with delivering to the heart, but that's inevitably going to be overcome. Gene transfer. So this is what's usually considered gene therapy. This is delivering a gene to the heart, usually with a viral vector. So this is where clinical trials have started for a few different cardiac conditions. And then gene editing. So CRISPR has really changed or is going to have a huge impact on medicine. And trials are ongoing for many of these things. And as many people know, so we'll be talking about the in vivo forms of gene editing, but you guys have, I'm sure, probably heard. So the first CRISPR therapy, which is a cure for sickle cell disease, has been approved. The FDA approved it in December. So if you have sickle cell disease now, it can be cured. And then epigenetic editing, we'll talk briefly about this. So this is where you're not changing the DNA itself. You're changing methylation status on the DNA. And this will likely be very important in the future. It's a way to silence genes without changing your DNA. So we'll go through briefly the therapies that have reached clinical prime time, in addition to discussing the tools, and go through kind of overall potential for arrhythmias and cardiomyopathies and remaining obstacles. So getting into it. So RNA knockdown. So what does that mean? So the two different tools are antisense oligonucleotides and small interfering RNAs. So how these work, so genes are, so it's encoded by DNA. And then with transcription, so part of gene expression involves genes being transcribed to mRNA, and then mRNA is translated by ribosomes into proteins. So those are the functional components. So this intermediate step, mRNA, is a way to, if it can be targeted, it's a way to prevent gene expression of a gene. So there's two different ways to do this, small interfering RNAs and antisense oligonucleotides. The mechanisms are slightly different, but the bottom line is the machinery essentially binds to the mRNA of your target gene and degrades it. And if you do that, the gene won't get expressed. And for conditions where you can tolerate either knocking down the whole gene or a portion of it, this can be therapeutic. So this is now, being used clinically. So it's for the two examples for RNA knockdown that I'm going to give are being used clinically are for cholesterol. So inclisiran is a is an RNA tool, siRNA tool that enables you to knock down PCSK9. So PCSK9 we know is very important with lipids. So it was a genetic story that identified this, and Canada was involved in this. So people that have inactive PCSK9 have really, really low LDL levels. So if you knock down PCSK9 mRNA, which is what inclisiran does, LDL levels go down a whole lot. So one of the benefits of inclisiran is that it only needs to be given once every 6 months. So some people don't like to take statins every day. If you take inclisiran once every 6 months, you get a big drop in your cholesterol. So this is approved in Canada and is being used by lipid clinics across the country. Another example, this is for an ASO, so antisense oligonucleotide. So LP(a) is, as we know, it's important in risk of coronary disease. And interestingly, the LP(a), it's not dependent on diet or exercise. It's almost entirely dependent on your genetics in terms of whether or not you have LP(a). So someone that has high LP(a) levels, there's nothing that they can do about it. It looks like there probably will be small molecules that end up working for it. But right now, the way that it can be treated is through ASOs, and there's also siRNAs that have been developed. So they work really well. So they target LP(a) mRNA, knock it down, and you get dramatically reduced LP(a) levels. So this is an antisense oligonucleotide that is now being studied by Novartis in a pivotal randomized trial called LP(a) Horizons. They expect data to be read out in about 2025 to see whether or not it changes endpoints or cardiovascular outcomes. And then siRNA, so there's multiple companies now that have siRNAs for it. And this also works really well. So, and can be long lasting. There was data at AHA this year for a single injection that can last up to a year. But it's another way to knock down LP(a) levels. So where are we with cardiology? So these tools can get into the liver really well. So that's where the knockdown for both PCSK9 and LP(a) happen. Getting these into the heart, people are working on modifying the ends of these molecules so that they're identified by receptors on the heart to take them up. So there's a company called Ionis Pharmaceuticals. They drive a lot of the ASO work that have started to look at it for phospholamban cardiomyopathy. So phospholamban cardiomyopathy, it's a form of cardiomyopathy where you can get dangerous arrhythmias and also heart failure. And it's driven by, or the most prominent genetic change that in phospholamban patients it is a genetic change called R14del. So essentially, the 14th amino acid arginine is deleted. It's a founder effect. A lot of these patients come from the Netherlands. They have experience with hundreds and hundreds, and I think thousands of these patients. But we have them all across Canada. People often that have immigrated from the Netherlands. They're all over the world. This is interesting. It seems like you can tolerate. So these people develop it. They're heterozygous for R14del. And it appears that you can knock down one copy of phospholamban and the heart can still be healthy. So they've developed an R14del ASO that knocks down the phospholamban copy that has this aberrant R14del variant in it, and it seems to rescue the phenotype in mice. So you can see here in these different captions. So F, if you look at ejection fraction and LV dilation, the mice that are treated with the ASO, everything seems to normalize. It seems to protect against fibrosis. And then from a survival perspective, this slide I here, or panel I, you can see that the mice essentially end up with normal life expectancy, whereas the R14del mice, you can see here the red curve, a lot of them die, quite early on at about 5 to 10 weeks. So that's really exciting. We're in touch a bit with Ionis, and they seem very interested in moving this forward to humans, but it hasn't gotten there so far. But I think it's likely a matter of time. So that's kind of background in terms of RNA knockdown. The key with RNA knockdown is you have to be able to tolerate some of the gene protein knockdown. You don't need the full 2 copies being expressed all the time. And it's particularly beneficial when it's usually like a dominant negative gene or genetic variant that's involved. So switching gear to gene transfer. So this is where in cardiomyopathy and arrhythmia, multiple clinical trial programs have started. So what does this involve? So this is kind of typical gene therapy. It uses an adeno-associated virus, AAV. So previously, people may be aware, back in the 90s, people were trying to do gene therapy with adenovirus or AV, and that didn't go very well. There were deaths. There was a significant issue with immune response. So the body would see this adenovirus and mount a significant immune response, and people could get really sick with this. AAV, adeno-associated virus, the immunogenicity seems dramatically reduced. There's still immune response is still important, and people that are being considered for AAV therapy, you have to check to make sure they don't have antibodies to AAV. Because if they do, then they can't get it. But assuming they don't, it appears that it can be well tolerated. So what happens? It's an intravenous injection, and the AAV vector, which is the delivery vehicle for the gene. So the viral vector has the gene that you want to deliver to the heart in it. So the vector gets taken up and then incorporated into the nucleus, and the hope is that the AAV vector, it forms something called an episome in the nucleus that will just essentially serve to allow that gene to be expressed. There is the possibility that it can get integrated into your genome, but it's preferred that doesn't happen, because if it gets integrated into the wrong spot, it can potentially cause problems. In terms of the episome, one of the considerations is this durable? Will it be present lifelong? And that's still being worked out, but the data seems promising. So in terms of examples in animal models, so this has been explored about 10 years ago now for calsequestrin CPVT. So this is an autosomal recessive form of CPVT where if both the copies of calsequestrin aren't working properly, people can have dangerous arrhythmias related to it. If you replace about 50, it seems like the key value is like about 30 to 40% of this gene of what it's supposed to be, you can cure mice. So this is what they did in the study. So calsequestrin mice, they get lots of arrhythmias. If you deliver, so the R33Q INF, that's essentially the gene therapy. Their risk of arrhythmias goes down dramatically. They essentially behave the same as wild type. So there's a company that's working on bringing Cas2 CPVT gene therapy to humans. It hasn't started yet, but it's in the works. Something that has started, and I'll summarize what's made it to humans so far, is PKP2 gene therapy for ARVC. So PKP2, you need both copies of your PKP2 gene expressing properly for heart health. If you lose one copy, it's called haploinsufficiency, that can cause ARVC. So in that context, for people with PKP2 variants, that's the most common cause of ARVC, PKP2 ARVC, and they're usually truncating variants. So essentially they undergo nonsense-mediated decay and they're not expressed. In those patients, if you can deliver a healthy copy of PKP2 to basically get your levels up, people think that may provide a cure. So there's been multiple studies actually within the past year that have been published for mice, and we knew about these for the past few years, even before they were published, because that was the rationale for the gene therapy studies. But they show that the mice are essentially become cured after they're treated. So it's an injection, intravenous injection, and then this AAV, this viral vector, delivers PKP2 to the heart, expresses it, and seems to rescue, prevent onset of the condition. And if it's given after the phenotype's developed, it largely gets better. So yeah, we'll talk a bit more about where the clinical trials are, and kind of a neat adaptation that of both RNA knockdown and gene therapy that Mike Ackerman at the Mayo Clinic is pursuing. He's pursuing it for long QT syndrome. So long QT syndrome, usually for these genes, so for example, long QT1, you need full expression of KCNQ1. That's the genetic culprit for long QT1. If you have half the amount, then you get long QT syndrome. One of the challenges with gene therapy and also any of these other things is that there's hundreds and probably even more of different variants in KCNQ1 that can cause long QT. It's likely not going to be possible to develop drugs for each single variant. So is there a way to get around that? So Dr. Ackerman has a clever way of doing it, whereby hearts are transfected with a vector. He uses lentivirus, wherein there is a RNA knockdown component that knocks down both copies of KCNQ1 in the hearts, and at the same time expresses a normal copy of KCNQ1 that has been engineered so that this RNA knockdown tool, it's immune to it. So it's small hairpin immune is what this stands for. So essentially, it's a way, no matter what variant is present in KCNQ1 that's caused long QT syndrome, everything gets knocked down. Their own kind of their own KCNQ1 that they produce. And it's replaced with healthy KCNQ1. So that seems exciting. He's indicated that he's hopeful that they're going to be able to start human trials in the next couple of years. So far, it's mainly been in cells, but that they've reported so far. But there's rabbits that they're studying. So I think that's exciting and interesting to see where it goes. So in terms of where we are with gene transfer therapy in arrhythmias and cardiomyopathies. So there are phase 1 trials ongoing for Danon disease. So these are being driven by a company called Rocket Pharmaceuticals. Danon disease is a glycogen storage disease. It's X-linked. It's related to the LAMP2 gene. So if LAMP2, so it's particularly in males, they only have one copy of LAMP2. So if it doesn't work, gene therapy is a way to replace that abnormal copy, and they have promising results so far. MYBPC3 HCM, so that's a form of hypertrophic cardiomyopathy that develops because of loss of function in the MYBPC3 gene. So similar to the PKP2 truncating variants, it's MYBPC3 truncating variants. If you deliver a healthy copy of MYBPC3 through a virus, through an adenoviral vector, AAV vector, they're hopeful that will provide a cure. There's also trials ongoing for Friedreich's ataxia, and I believe Quebec's participating in this. So that's a multi-system disorder that has a important heart component. So they're delivering the virus to the heart and hoping it works. And yeah, so PKP2 ARVC, as I mentioned, there's at least 3 companies right now that have launched PKP2 ARVC trials. And some of them have begun enrolling, not all of them, but it's here. People are trying this, so it'll be very interesting to see what happens. So now shifting gears from gene therapy onto gene editing. So this is CRISPR, and I think this holds potentially the greatest potential. It's a way to change our DNA for the better. There's multiple different versions of CRISPR. There's the kind of CRISPR 1.0 is the nuclease. So essentially cuts DNA and then relies on the cell to put it or repair it afterwards. Then there's base editing, which is people oftentimes call CRISPR 2.0. It's like a pencil and eraser and can do specific base pair changes, transitions, and transversions. And prime editing, which is potentially the holy grail for DNA editing. It's so whereas base editing can change a single letter to another, or certain single letters to certain other letters. Prime editing can potentially change whatever you want. It can change single letters. It can change many letters in a row. It's potentially a way to insert large genes in a very precise way in the genome. So we'll see. That's at an earlier stage, but people oftentimes call that CRISPR 3.0. And then epigenetic editing. So there's different ways to do epigenetic editing, but CRISPR seems to be an effective way to do it. So as mentioned, so the Cas nuclease, this is CRISPR 1.0. What it involves is it's essentially, so there's Cas is a nuclease. It cuts DNA. And when that is paired with a guide RNA, so that's the sgRNA here, this tells this DNA cutter where to go in the genome. So the genome has 3 billion base pairs. This guide RNA tells it exactly where to go. The nucleus essentially follows along. It binds to the guide RNA in this thing called PAM, or a protospace or adjacent motif, and then cuts. And it causes a double-stranded break. And after that double-stranded break, there's two outcomes. Usually in cells, what happens is predominantly non-homologous end joining. So essentially the cell kind of sees that there's been this double-stranded break and then wants to put things back together. And it can do so in a variable way. Usually you end up with frame shifts after this. So it's a way to essentially knock down or destroy a gene permanently. So it's knocked down, but unlike with siRNAs or ASOs, it's permanent. Once it's done, it's part of your DNA, and that's it. So Cas9 nuclease is what people are using typically. Cas12 is just a variation on it. Base editing, as mentioned, so it's a way to, instead of kind of destroying a gene or knocking it down, this is a way to change the letter. So you can potentially do a corrective change from the disease-causing mutation back to wild type. There's two different types of base editors. One is an adenine base editor, and another one is a cytosine base editor. So you'll recognize A is one of the bases in DNA, and C is as well. So what base editing can do, it can change an adenine to a guanine, so an A to a G, and a cytidine deaminase or a cytosine base editor can change a C to a T. So that can be very, very helpful. And if you just do the reverse strand, then you can do a T to a C and a G to an A as well. So there's about 8 permutations that these can address. So yeah, this doesn't involve double-stranded DNA breaks. What happens, it's a single-stranded break, and then you modify that base with a deaminase. And then once that happens, then the reverse strand is part of the repair mechanism, changes the complementary base pair, and you get this change. So pencil and eraser, you don't get a double-stranded break. You can do a targeted adjusted letter change. And then, as mentioned, prime editing is the word processor. So that's involves something called a reverse transcriptase to incorporate nucleotides. But you can incorporate just one, or you can incorporate many. And as mentioned, in addition to being kind of a word processor putting in a bunch of different letters, it can also potentially insert full genes. So both prime editing and base editing were developed by the same person, a guy named David Liu in Boston, and they hold lots of potential. And then epigenetic editing. So as mentioned, this is where you turn genes on or off. So whether or not a gene is expressed is dependent on methylation status in the promoter region. Methylation is, so if you remember from organic chemistry, there's these CH3 kind of entities that bind to areas of DNA. If you bind or a CH3 is added, sometimes it turns a gene off, and sometimes it turns a gene on, depending on the particular location. So this is a way to turn genes on and off without actually changing the DNA base letters. So what's happened so far in cardiology? So in mouse models, we think this is still evolving, but you probably only need one copy of RYR2. If you lose a full copy, it seems like it may be tolerated, although we're still learning about this. But this was from Xander Waring's group, where they transfected mice with CPVT and essentially destroyed the copy of the gene that had the gain of function allele, but left the healthy allele, and the mice were cured, and everything seemed to be normal subsequently. The heart muscle and everything was fine, and their vulnerability to arrhythmia went away. So yeah, this hasn't come. So CRISPR for the hearts has not come to humans yet. So this CRISPR machinery was delivered with AAV, so adeno-associated virus. It's still the packaging and stuff like that. It's not ready for humans yet. They are able to get, so in addition to sickle cell, so for the sickle cell cure, they take the cells out, treat them, so it's ex vivo treatment, and then they put everything back in with essentially a bone marrow transplant. For in vivo, they're very good at getting this CRISPR machinery into the liver. So for genes that are in the liver that are relevant to disease, they can target them now. So there's a company called Intellia that has done it now for both amyloidosis and hereditary angioedema. So this was published in the New England a few years ago. So people with amyloidosis, it's related to aberrant activity of the TTR protein. So if you get rid of the TTR protein, which seems to be tolerated, you can potentially cure amyloid. So patients were treated with a single injection, and then they track TTR levels after, and you can see TTR levels, these are down how many percent? So down 80%, 84, and 96%. So this was a kind of initial proof of concept in humans. Since this study, they've presented some additional data at this year, actually, an American Heart Association meeting about the potential cardiac benefits of it. So single injection, your amyloid is potentially cured. Same kind of thing with hereditary angioedema. These people get flares of angioedema, and it's related to the kallikrein protein. And it seems like you can knock down a lot of the kallikrein protein, and people will be fine. So that's what they did here. Single injection, kallikrein protein goes down dramatically. And after doing so, you can see here in terms of these angioedema flares, these are percent reduction in flares over time. So this is 1 to 24 weeks, and you can see generally over 95% reduction in flares. And it's just a single injection. So seems very promising. This was just published a month ago. And then in the cardiology domain, so what's happening? So cholesterol, as mentioned, they can deliver those things well to the liver. So there's a company called Verve Therapeutics that showed in monkeys a few years ago that if you deliver this CRISPR base editing, so they're using base editing, whereas Intellia is using the nuclease CRISPR 1.0. Single injection into monkeys, you can dramatically lower their PCSK9 levels over 90%. And then this is associated with a 50% reduction in LDL cholesterol levels. And it's durable for the life cycle, or for monkeys. I think they're now to about 3 years, and the cholesterol remains rock solid low. So they've now done it in humans. So at AHA this year, they presented initial data in humans. So this was dose ranging study, and it's just kind of early data. It was, I think, 10 patients. And so single injection of their base editor resulted in a dramatic reduction in PCSK9. And you can see this is the reduction in LDL cholesterol. So these patients that were injected, they were people that had familial FH, so genetic changes that caused their cholesterol to be high. They've now had a genetic change to lower their cholesterol permanently. And that should be protective. People talk about cholesterol years now in terms of creating risk for heart attack. So the longer your cholesterol is low, the less likely you'll ever develop a heart attack. So this was for inclisiran, but you can imagine if people got this injection when they were 30, people would probably never get heart attacks anymore, or at least the prevalence would go down dramatically. So that's kind of an overview of tools, gene-based tools for these conditions, and it will be interesting to see how things evolve. So yeah, for RNA knockdown and gene editing, still need delivery vehicles for the heart, but progress is being made. AAV-based therapies, they're here. So people are being treated. An important concern is the immune response. So it's less of an issue than with AAV-based therapies, but it's still going to be important to see how all this plays out, especially in something like ARVC, someone gets an AAV-based therapy, has significant inflammation, is it possible that could cause more arrhythmia in the acute phase? We'll see. Gene editing, an important concern beyond establishing efficacy is the potential for off-target effects. You want that letter change at just that position. If there's 3 billion base pairs, is it possible accidental changes could happen elsewhere? Maybe, but there's lots of people are being very careful with that. And then, yeah, delivery vehicles for in vivo beyond the liver. It's just a matter of time. There's already a very promising lung delivery vehicle. People are using it to try to now cure cystic fibrosis. And that's it. So take home points. ASO, siRNA, they're here for lipid disorders. They're going to come for heart-based disorders soon. AAV-based therapies are here, and CRISPR-based therapies are here for some things and on the horizon for others. And then the last thing I'll just mention, so we have a trial, so along the lines of targeted therapies for these conditions. So we have a small molecule called tidglusib that we think is targeted specifically for arrhythmogenic cardiomyopathy. So it's different somewhat than these kind of nucleic acid-based treatments in gene therapy. But we think this is a molecule that's tailored for ARVC that in mouse models prevents development of the condition. So we're looking forward to launching this clinical trial, hopefully in the next few months. And Ottawa will be a very important partner in this study. So I just thought I'd mention that. It's a bit off topic, but kind of somewhat aligns. So that's it. Questions?
It's amazing, Jason. Thanks. Every time I hear it, it just sounds so fascinating, no?
It's here.
The Holy Grail, and it's kind of finally here. It just makes me wonder a little bit. I know in the earlier sessions before the breakout meetings, there was a discussion this morning about trying to get industry partnered to fund treatment for rare diseases. Mm-hmm. Do you think that now the technology is there, that most of the R&D is done, and then tweaking is a cheaper part, so it's going to become more favorable, or where do you see the future?
Well, so industry has a huge interest in developing therapies for these kind of conditions. I mean, the one caveat is the cost. So the sickle cell cost right now is $2 million US dollars. However, from a cost efficacy perspective of a lifetime of sickle cell crises, people going back and forth to hospital, it's anticipated to save the system a lot of money. I think for all of these rare diseases, companies are very enthusiastic about developing it. Like even so, PKP2 ARVC, that's not a common disease, but there is at least 4 and I think multiple, even more companies that all have PKP2 ARVC programs developing. So I think and the other genetic subtypes. It's just so PKP2, I guess it's the most common. So there is kind of a bigger addressable market. But yeah, for the rare ones as well, like these CRISPR companies, they're going after kind of really rare things. But the idea is that the therapies, they'll potentially charge a lot. But if it's if it's truly is a cure, then charging $1 million or whatever is fine. The cholesterol one they're anticipating because it's such a so they're developing it for heterozygous FH. They're developing for homozygous FH a target ANGPTL3. But for the heterozygous one, they're anticipating their costs are going to be a lot lower. The tools for CRISPR, these treatments are very similar to the tools or the building blocks for the COVID vaccines, the mRNA vaccines, and they're made for $100. So I'm sure these therapies won't end up being $100, but the raw materials, they don't cost a whole lot more than that.
No, but they're not coming back for refills. That's the issue. We're going to have to get around this idea that we're going to spread the cost over a lifetime and we're going to pay it up front, and someone has to be willing to stump up the cash.
Exactly. And yeah, that cost model, there's lots and lots of discussion about it now for sure. But yeah, it'll be interesting to see how it evolves. I'm
Judy.
just a scientist. I don't know how to sort that.
No, that's a great answer. Judy Avishai, I see your hand up.
Thank you so much. That was a superb talk. Do you foresee a world where somewhere in the future, for some of those conditions where sudden death can be your first manifestation, there would be newborn screening, and then just like we do for spinal muscular atrophy now, there is newborn screening, because if you catch it early enough, you prevent further damage. Do you see that in our future while most of us in this call are still alive?
Yeah. So I think that I think that exome sequencing, we're all going to probably have our exome and genome sequenced. Probably, it's in 10 or 20 years, kind of standard. Like right now, it doesn't cost much at all to do an exome or a genome, but we don't know how to use that data that well, for the most part. On a population level. But I think that in all likelihood, in time, it will become, routine for people to have, in your EMR, to have your exome or your genome done. And in that context, if someone it very well may happen at birth. In terms of when it's going to happen, I don't know. Is it going to be in our lifetime? I don't know. But I definitely think that will likely occur. Someone's born, they get their exome or genome done, and then if there was a damaging variant that was identified and there was a CRISPR cure available, then you get it fixed, and then you would never have to live with that disease. But that's more of, I'm purely speculating. But I think from a science perspective, it's absolutely possible. And if you have like a CPVT causing variant or something like that, and are born, and your parents are told, they have CPVT causing variant, you can get this fixed with a CRISPR cure. Do you want it, cured? I think most people would say yes, assuming it's shown to be, effective and safe. One of the challenges, I think, as well, is how long do we have to go before it becomes routine? Like, what is the period, the safety data that has to be accrued before it's considered safe? This is something that the company Verve is dealing with a lot. Like, they want to, you can imagine if everybody got a PCSK9 treatment and dramatically lowered your cholesterol, and nobody got MIs anymore, that would be incredible. However, there are very good therapies for cholesterol right now. So there really has to be almost zero risk to kind of potentially institute something like that. So how much data and how much time, has to be accrued before that we kind of get to that point? I don't know. We'll see. It will be very interesting. Like, I think the FDA, it took them a while to start approving in vivo CRISPR treatments, because most of the initial studies were all being done outside of the United States because of the FDA being cautious. New Zealand's been a driver in the UK, but they've started to open things up, and Intelli has gotten approvals to do things, and so has Verve, I'm sure it's just a matter of time. There's so many of these CRISPR treatments that are being developed now by multiple companies. It's exciting.
Thank you so much. Newborn screening has examined whole exome sequencing in some jurisdiction. It's not as good for biochemical targets, so that's why it's not yet ready for prime time. But as we're transitioning to genome and we understand more of that data, I agree with you. It's a super exciting world. Thank you so much.
Great.
Jason, do you think there's any more work? There's multiple mechanisms of how we're delivering these things now. Do you think we're there yet? Do you think we have all the tools that we need? Or do you think there's still work to be done in that front?
Yeah, for sure. Well, as far as for the heart, so the CRISPR machinery can get to the liver. There's no way to get it to the heart right now. I don't think AAV or adeno-associated virus is the way to go for that. Lipid nanoparticles seem to be good, but will they be able to get to the heart? I don't know. But so delivery vehicles are going to be super important. I think as well. I think there's definitely, lots of progress that will still, be made, huge progress, I have no doubt, over the next decade with all of this stuff, in terms of, efficacy and ensuring no off-target effects. It seems like each company, it takes them a long, this is essentially it's a, it's not a PCR reaction, but you should be able to just dial it up. But I think there's a lot of trial and error and kind of finessing in order to make things work. So yeah, but I think, and beyond kind of base editing and prime editing, I'm sure there's many, there'll probably be lots of additional forms of editing that come out that may end up being safer. One thing with prime editing is reverse transcriptase has an error rate that is super, super low. But if you're changing letters in billions of cells, you have to have a incredibly low level, or you're going to potentially get artifacts. So people are wondering about that. We'll see how it evolves.
Yeah, 1 in 100 million error rate in that number of cells is it shows up eventually. Eh?
Yeah.
I mean, I think that's the other technology that might make people wary initially, is that particularly with CRISPR, once you've done it, it's done. Yeah, you can't just turn it off again once you've delivered it. So it'll be interesting to see how people respond. Fantastic. We're coming up now, so the next sessions are going to start in about 3 minutes time. So I'm just going to see if there's any other questions and check the chat. There's nothing else there. We'll finish up here. I'm just going to thank Dr. Green. Thank you, Jason, as well, for coming. It's been great to have you with us. Thank you to the people who have attended as well. It's been a great meeting. And then we'll see you all again next year. When we leave, please click on the breakout box, and then you can then choose the session that you've signed up to for 2:30. Thank you so much.
Great. Take care, everybody.
Thanks, Jason.
You bet. Anytime.